While you are taking the history of asthma, one entity you need to be aware of is aspirin-sensitive asthma. So there is a known association between asthma and sensitivity to aspirin or any other non-steroidal anti-inflammatories, and like Motrin or like ibuprofen and other NSAIDs. And this is basically what aspirin-sensitive asthma is. And it affects about 1 to 5% of asthmatics. And it's more common in patients with severe asthma. About 20% of severe asthma patients, they have aspirin-sensitive asthma. And also those with frequent hospitalization because of their asthma. And also in some ethnic groups like Eastern European population or Japanese population. So maybe there is some genetic element to it. So what it is exactly, so classically described as the tetrad of asthma and nasal polyps and then aspirin intolerance. And these three are known as Samter's triad. And then the fourth component is chronic hypertrophic eosinophilic sinusitis. So these are the four components of aspirin-sensitive asthma. So classically and typically, perennial rhinitis is kind of the first symptom in this syndrome. And this is followed by aspirin sensitivity. And then later in the course of the disease, patient can develop nasal polyps. So it kind of starts just like any rhinitis, perennial rhinitis at the beginning before it's being recognized. I mean, the nasal polyps is the most characteristic maybe, but it develops a little bit late. So aspirin, even with small doses or any other NSAID, typically causes wheezing, facial flushing, rhinorrhea, and conjunctival irritation, resembling any allergic reaction. So it can be really hard to distinguish between the two, especially at the early course of the illness. And pathophysiologically, there is no evidence that IgE-related mechanisms are involved. How to make the diagnosis of aspirin-sensitive asthma? It's usually clinical diagnosis, so you have to suspect it and keep it in mind when you're taking the history of asthma. And it can be confirmed by the sensitivity testing, although this carries the risk of anaphylaxis, so you have to be very careful. But usually the clinical diagnosis is quite enough in these patients. Another important entity of asthma that you need to be aware of when you're taking the history of asthma is occupational asthma. It's the most common occupational lung disease, and there are many materials that can be associated with exacerbation of asthma. So for example, acid anhydrides in plastic workers, complex amines in photographers and painters, methacrylates and latex in lab workers, proteases in the detergent industry, cobalt, nickel, and platinum in metal grinders and platters, wheat in bakers, and western red cedar in carpenters. So occupational history is very relevant in patients with history of asthma or asthma-like symptoms. So one characteristic finding is that symptoms are actually worse at work, and they're better during the weekends when the patient is not working or on holidays. So this is very characteristic actually. Early recognition is key, as you can imagine, because if removed from exposure within the first 6 months of symptoms, there's usually complete recovery. So keep that in mind. It's very important. Also, you need to be aware of exercise-induced asthma, EIA. That's really important variant of asthma. It's actually a very common trigger of asthma, especially in children. It's usually worse in cold, dry climate more than in hot, humid climate. And it's also more common with certain sports. Most of these are associated with cold weather, like cross-country running, overland skiing, and ice hockey. And less common in other sports like swimming, and it's actually worse with intense exercise. So the more intense the exercise is, the more likely you're more likely to get severe symptoms. The mechanism is not exactly known, but it could be linked to hyperventilation that happens with exercise, It might lead to water evaporation from the airways and increase in the osmolality in airways lining fluid as a result of that, and that can trigger mast cell mediator release, and that can lead to bronchoconstriction. So this is one possible mechanism that could be can help explain exercise-induced asthma. Now, it typically start after the exercise has ended, and most of the time patient recovers spontaneously within about 30 minutes afterwards. A patient might complain of coughing only without wheezing, and that might really make the diagnosis really challenging in this situation. So be mindful of that. Diagnosis, if you clinically suspecting it but you're not too sure, you can do exercise challenge. And if you're able to demonstrate a decrease in FEV1 by more than 50% within 5 to 10 minutes after exercise, and that should be reversible, then you can make the diagnosis of exercise-induced asthma. Of course, prevention is almost the best treatment for these patients, and it can be provided by regular use of inhaled corticosteroids. But prior use of bronchodilators like short-acting beta agonist given 15 minutes before exercise is actually the most effective preventive medication. You can also use leukotrienase inhibitors. Another measure you can use is ask the patient to wear a mask. Yes, wearing a mask during exercise, even without COVID. So yeah, these are the kind of the treatment, but they're actually kind of a prevention of exercise-induced asthma. Another important correlation I want you to be aware of is the obesity and asthma. There is a strong correlation between the two, and obesity is now well known to be a major risk factor for asthma. So both abdominal obesity measured by the waist circumference and increased BMI, they show a strong correlation with risk of new onset asthma. And patients with asthma and obesity, they often have excessive symptoms and are less responsive to corticosteroid therapy. So they might be a little bit more difficult to treat in some patients. The mechanism, of course, as you can expect, is not very clear, but it could be due to direct effect of excess adiposity on the lungs, or could be due to influence of obesity-related inflammatory processes on airway inflammation and hyperreactivity. One randomized controlled trial found that addition of aerobic exercise plus resistance muscle training to weight loss program, which we always recommend in patients with obesity, it found that this combining all this might improve asthma in patients with obesity and asthma. So it has some therapeutic implications as well. So keep that in mind when you're taking history of patients with asthma, and look at their weight gain and look at their waist circumference and BMI when you're evaluating them.